That's true.
He might just be
Why
like talking
is
to
this
Albany.
Bridget so high up?
This is his show.
He's also pissed is what he got.
Study a little for that.
I know. Aaron, I know.
Okay, I don't like this. Ew. Wait, that's shaking. What's shaking? Okay, when they do it in the stomach, they like push, they like take a patient and they push their stomach. Yeah.
When's your birthday?
I'm pretty sure class is already started and everything.
Oh, I thought he might have just like been talking to Albany.
Are you lecturing? If so, we can't hear you in Augusta.
Thank you, Aaron.
I think there were a couple other people who finished up the quiz.
Oh, you look.
Aaron was on top of it.
Are you lecturing?
Are you lecturing? That was great. I wonder if Dobbs is friends with him.
Monday.
Today's the 25th already.
Do we have to do anything for summer?
March went by
Do
super
we have to do anything?
Everybody's done on.
If you didn't take it all out in the beginning, you can like add loans.
Everybody good?
You just fill out that form.
You can see my slide.
I like did it over spring break and then like added money. Go to the student financial aid office website and then there's like a change in aid
One of these days,
website.
it's all technology figured out. Well, somebody's speaking somewhere else.
What?
You can say hello or anything.
From where?
Somewhere else.
Augusta.
Awesome.
Good.
Awesome.
The first time it was very muffled, very quiet. Alright, so this was probably, I expect, hopefully the easiest patient case we've had to date. But this is, speaking of,
She being serious?
I was like, wait, what?
He said easy?
In terms of the amount of notes, the amount of procedures, the amount of labs to go through. And so we talked a little bit about more so and ABP, about ID consults, or effectively consults, and how you ask to see a patient. And so we'll come by, it may be on day 1 of the vision, maybe on day 5. We have a couple of those ones that were on day 20 and 30 of the vision. And so you're ultimately having to go through all of their lists to figure out what's going on. If you do appropriate things up front, if not,
It'll tell you in the
educating,
Dina
you
how
go
much
back
you
and
took
rectify
out.
the situation, can we make things better going forward. But in terms of the purpose of this class,
That's the thing,
really
like, if you go out and
problems
you have to
that
have
can
like
still
money left
exist.
over from
You're still going to
took out the
figure out
whole
the
amount, but they're not
practical
gonna do
problems.
that.
We're going to make sure they're on appropriate therapy for whatever duration it may be, making sure that
Did you take all of the Rad Plus and the,
also
they give you part of the Rad Plus Lumen?
and so just
That's what they would do. They won't give you more than you're allotted for a year. You look in your bank account, see if you have enough to pay $10,000.
There's $10,000.
It's
A little over $7,000.
GERD, that
For our
colitis.
rotation.
Oh shit, I gotta take one. Kerosene
Yeah.
for 2 years. He has an allergy to sugar. Nausea, vomiting, diarrhea, abdominal pain that based on
You probably weren't talking about tuition. What's this extra?
yeah, no history of peritonitis, but he was admitted with peritonitis, was severe antibiotics at this point. So we'll go with number 4.
Yeah, I usually like try to take out just enough to cover tuition. But
By hand?
I have to build on my hand.
I don't know, I like did some miscalculations this year, so I like ended up taking
Oh, I have to do it
like
back, right?
extra for like each semester without meaning to. But it turned out nicely because now I was like, I just needed a little extra money.
You don't want to think about.
Yeah, I think I'm gonna go ahead and do that right now.
I have to look at mine.
Yeah, they like already added it like to my thing. I like did it over spring break and I just got an email like a few days ago saying that your financial. Yeah, they do it like that. Who are you?
Wait,
Who are you? Right? I just always ask.
Let's see.
I accepted. But
Your microphone.
if you ask for more than 1,000, it's going to give us
The peritonitis.
Peritonitis, okay.
How much should they give us?
All right, so in terms of subjective portion, how do you?
Is there a way to see what I'm gonna owe for summer?
Abdominal pain.
I just took as much as I can, which is why not.
Fluid reviews course.
Do I have slides?
Yes, sir. If you're typing anything, you can't see it.
I have a Word document on it.
Hope you
We
can't
can't
see
see
it.
it.
Where are you?
If we can, then probably nobody else can.
Augusta. Like, we just see you.
Can Savannah see anything that I'm typing?
I'm at Jamal.
Savannah can see what you're typing.
Okay, not that. Well,
We'll get
everybody
Ronald.
will work.
Why are we having so many problems today?
There's a little tiny picture of you in action, but I can't see anybody. Can you see it happen?
Yeah, they
Somebody in a red shirt.
We should just
jacket.
cancel class.
Girl, I'm see it. Okay.
How are all of their mics not working?
That's what I
I
said.
find that really hard
Yeah,
to believe.
so Dr. Chastain, we can see the Word document, but not the slides.
Okay.
We can't see you guys.
As well as you need to listen.
Yeah, girl.
And it appears that several of the group's microphones are not working. I can't really get a handle. None of them? Okay, someone try it. Can you hear any of that? Okay. All right, so it appears that the microphones are not working in here, so I'll talk to IDTO, but just so you know.
Just say we're going to get Ronald.
See?
I'm sorry, I figured.
Ronald will
I
fix
can't
it.
see
What
it.
did you say?
We're going to get Ronald in Augusta.
Okay, thank you.
Like our summer balance? Is it on there yet? Oh, I don't know. I haven't checked. Probably not. I don't even know where I would in the student account.
No, we would have gotten emails that new charges posted
Oh,
there.
yeah, that's true. I just did it based on like what it cost last year. Like, how much money is your tuition?
I think we have more credit hours this year than last year, right? For
Should
this
be.
summer?
Should be 10.
I guess I
What did we have last summer?
Oh, I like asked a people. I was like, how much was your summer tuition?
Ronald is not here.
This is why all this is happening. Ronald keeps everything in line.
And all of this truly happened is age, of course his name, and some other identifying characteristics have all been changed. But this was a real patient. Just to kind of give you a little bit of an idea in terms of what this incident means. And we really did get asked at this point in time from an ID consult service to see him and to assess what all was going on and figure out what our plan was moving forward. And we'll just say the first day we saw him, it was quite interesting. There were quite a few things that were problems that had been going on for the duration of his hospitalization for 4 days that nobody had called or done anything with it.
Dr. Chastain?
Yes.
Okay, so I just talked to IDTO and he said, Chris said that he'd have to do an audio reboot to get the microphones working again. And he can do that, but it means that it interrupts class for about 2 minutes. What would you like to do? Do you want to continue on in silence, or do you want to stop for 2 minutes and see if we can get them working?
I guess Augusta needs to see.
Oh, Augusta can't see, okay.
Maybe we might as well go ahead.
Okay. Yeah, why don't we stop for a couple of minutes, and see if we can get things working. Okay, all right, thanks.
Wait, tell her I gotta go.
Oh, it's the perfect time to do so.
Yep.
I don't think so. The other
Does that mean that she can stop sharing?
Should you? Aw.
Is
It says stop sharing.
Just go press it. Just wing it. I won't tell on you.
Just hit the end call
What?
button.
I'm sorry.
Just hit the power button.
It's red.
Just turn off all the lights.
Every single one of them.
Yeah, just press it.
And- yeah.
The other, because the other time I tried doing it, I didn't even do anything. So
Oh, you can just, I wonder if you can just, for the unsubsidized loan, for the better loan, you can just, because I only took out for Fallen Springs, I just took out the maximum amount that you can off somewhere. Right? That should cover tuition.
but if they only gave you the 33,000, you already took it out. So
They
how
gave me more last year. I took summer classes, like that was like, when they give you an estimate, like the hours you're registered
Right.
for. So if you add some more hours, then.
maybe. I mean, I would try it and see.
I'm gonna have to call somebody, which is over my head.
I'm probably gonna call the hospital.
I'm gonna call them.
The only thing that sucks about college is you have to sit on hold.
Okay, how long are we?
Hours.
Well, I called them in previous years, and it's the worst, because one time I called and I talked to somebody forever, and I'm thinking about pharmacy students.
And that's what's so annoying because
And you get like bounced around to 10 different people. Like,
I don't understand what's so complicated.
How many, you said 10 hours.
It's 10 hours.
May 15th and August 2nd.
Yeah, whatever the dates are for our rotation. For
Wait, we have to change our
I'm if I didn't take out the whole amount.
We just have to pay summer tuition.
Like if you need money.
She said like 7,000. Just go to the hospital.
Go to Osmo.
And then do, but go in and then say, no, the
Office of student.
same thing.
It's
Duh.
hospital is the OSM.
Oh, technically, we're gonna start our other one before that.
What?
We're gonna start our third one before their senior ends.
They like, you pay within a month of the semester.
But I think you could put that into, I think that might go in with the fall. Like block 3, I feel like maybe that goes in the fall.
I feel like we're gonna have to pay that.
Because the only reason I put 10 is because like on our parent tab it says summer, like summer 2019 or whatever.
I think the college of pharmacy should have a financial aid person.
Call my dad and be like,
I
help.
just need a nap.
I'll have to take a look from the maple flavor juice rate. If anything.
From the baker. Oh, now here's us all. There's gotta be a way. Did you push that button?
It just, I don't know, I don't think it does anything. Because last time something wasn't showing up, I pressed it like a million times.
The
and
lady in
nothing
Ashby had
changed.
like, it was the last meeting, it was working now.
Oh, she
I know, and I was like,
That's what your graduate year was to add.
Wait, but, so for extended, I
Yeah,
don't
push it
know.
out.
I probably should have. But then what about this?
No, I think you should just do extended, because that's like separating it out. Start in May.
Yeah, there's no rush, but I think the safest way to do it is during the thing where it lets you put in dates. Because when I asked Dean Francisco last year for our IPPEs, he was like, if you do it that way, you'll get the money faster. This option where it lets you put in the dates and the number of hours.
Well, that.
Hey, Ronald's here. You can submit another one.
What?
Yeah, it'll just take longer to process.
Technologically.
So is he saying anything or?
And in the comment section, just be like, ask if I filled it out wrong.
But
Here,
then
use
we
this
also
one.
don't have the visual from testing.
we can hear but not see.
Oh, you found it? So you were like, help.
What room is he in? I know.
He's in Albany.
He's in Albany.
The lecturer is in Albany, yeah.
Oh, he's doing an audio reboot.
Oh, you said it would interrupt class.
He's rebooting something. We don't know what he's
The mic reboot?
Okay, all right. Oh, but just call him now.
Okay, but don't we have to do it until August 3rd?
They said that's considered the fall semester, so we would get money for that.
Essentially it is in our book.
And her, like that's how it's written. Like we only have 2 rotations that are technically summer, so I think it's
I'm gonna call them
I
tomorrow.
don't know what we're talking about.
We're talking about Alpha for summer.
Yes, let me just figure out how it works.
So did you say you know exactly how much it is? Like what did someone say it was last year?
I have the exact number, yeah. If I can find my phone.
Some of my requirements for university, I have to like. Okay, awesome. I think it's in the
Can the distance campuses hear me okay? This is Chris.
We can hear you in Augusta.
I thought I had it written down, but it was definitely over $7,000. I don't have the exact number.
Alright.
It was definitely over 7,000.
Less than 8?
Yeah.
Okay.
So like 73 or 74 or something. 2018, 2019.
What's going on? Am I missing facts?
We can't see what his presentation.
No, it doesn't make sense.
But we heard you that time. We heard you. We can see everybody. We just can't hear him. I don't know if he's displaying.
Oh, you can.
The problem we're having is that everyone can see his slides but us.
Oh, you don't? Oh, we don't have it here.
Yeah, everyone can see his slides but us.
It's, well, he's typing the words on.
So do I need to?
I know from like just now.
Yeah, I know that hello.
Hello.
Okay, I guess I'll just leave it. Okay, May 15th, August 2nd, with 10 hours.
Yeah, you can put in like the comment section that like you messed it up. So use this.
Wait, what's up? No, you did it right. I submitted it too quickly.
You did this over spring break, getting like confirmation.
They already added it.
So I declined almost $10,000.
No, but like it's already like it's like on my Athena that they added.
What does it say? It's gonna give it to you.
That it doesn't say, but it says like for the summer term, $7,000.
Yeah, they have loan disbursement dates.
Yeah.
Summer, so we won't get it.
Probably sometime in April.
After the bills are
Once
posted.
the fees post, they'll just take out.
10 hours
exactly.
from May
And then we
13th
reimburse the difference if there's.
to July, what did I say? What did I tell you?
It's 5/13/19 to 7/19.
Okay, that's what I was at.
And then we have that wonderful week break.
Whole week.
Yeah, we're doing like a week break stuff. It's like in the middle of something.
No,
So
between
we started the program and she's off 2 weeks. We're taking the next 2 weeks.
Oh.
They have one
We don't have a week.
I thought it was like the same for everyone. That's so weird.
Well, like, it's like, it's not the last week of July, it's like the third.
We have like a half of a week.
week.
Yeah, it's weird because like July ends in like the middle of the week.
Yeah, no, so like we get a weird week off.
Yeah.
From Wednesday until, like she gets the first week of August.
we don't have anything.
The actual last week's like half week of July or whatever.
Is anyone talking to anybody in Albany?
No.
Nobody talking to
Okay, we'll call them. Actually, I'll talk to them there. No, nothing for APG? I don't know if you're still in Seattle, right?
Hey, Chris.
Okay, we can hear.
This is Daniel. Can you hear me?
Yeah.
Yep, we've got you here in Athens. Thank you. Okay. Thank you.
So this is the last. So this is the last.
Oh,
2.
Do you know if our IPC final is actually a final? Or is there another final?
No.
No, that-
See, you have that. And then mine on the end of there.
Has to retweet it.
They haven't really said that.
That's how it was.
Yeah, I didn't know if they were like doing it the same way for us.
We just remind you.
No, it's all good.
Can't you just have to email it?
I feel like they would not like that.
I thought we could as long as you email.
IPC?
No.
Oh, yeah, for
So
sure.
then I can just go home Friday and not be back in Augusta.
Hey guys, I have some extra candy.
Yes,
thought you
please.
guys could probably
You
be
just
done with that.
made my day.
Yeah, enjoy it.
Thank
Snickers,
you.
it's only chocolate. Gotta get through this stuff.
Thank you.
You're welcome. Have a great rest of the day.
I think she's an angel in the sky.
Don't get some candy.
Lindsay, we went to the cutest candy shop and I wanted to go back and get candy. Delicious. I kid you not. We saw it and I was like, you know who would love this? Vincent.
Where?
In Seattle.
Yeah, it was amazing.
Is it a candy shop?
Yeah.
Here.
Vincent, you would have loved it.
I love candy in general.
Haven't had a Butterfingers. Get them all.
Yeah, they are.
Does someone at the airport like tell you that they
That's dope.
You like text or you like message me on Facebook? Small world. I'm gonna. I just ran into the Not me. Like,
Yeah, we were on the Yeah, we're gonna die. We're in the P2s or P1s. Yeah.
this guy.
Wait, what is this?
Oh my
It's the
god.
midnight. They're amazing. They're like my favorite. The midnight. I eat them out on the boat when I'm fishing. Fish dark chocolate. Nobody, look, it has ice in it.
I want another one.
No.
No. The normal one's full.
We should just cancel class.
I agree. I can't really hear him anyway. It's not in line.
You don't love it? What's your number one candy?
So did everybody hear? You can hear you, right?
Say we can.
We can hear you.
Okay. Thank you. So from a time perspective, to make sure we can go through all this, make sure we can go through all the case, I'm going to type out everything on a Word document in terms of the problem, plan, and monitoring, and then I will save the Word document. I'll try to type without abbreviations as much as possible, and I'll save it and I'll upload it to ELC. That way you all can have it. So we'll start walk through these a little bit. As for so all the microphones are fixed to have. Everything's good to stay on. And then can't see and Augusta. Alright, got it. Okay, so group number 4 we talked about, or I guess group number 20, sorry. We initially talked about that he had some abdominal pain from a subjective perspective. Any other signs and symptoms that would support peritonitis?
But I didn't put that wrong. Because that was more realistic.
Cloudy fluid.
Okay, so would that be more of a subjective finding or an objective finding?
I'm sorry, that's objective.
No, okay.
Nausea, vomiting.
Okay, so some nausea, vomiting, maybe a little bit of diarrhea. And again, those aren't necessarily indicative per se of peritonitis, but certainly support making the call. So from an objective perspective, you said you had some cloudy fluid. So some people call this effluent or dialysate. Anything else that would support it?
the culture came back with Citrobacter.
So Citrobacter from DI.
That's how you say that.
Anything else?
What? Was it that's how you pronounce that?
Yeah. Oh.
What was that?
Hmm.
It's the white blood cell count in the fluid that's over 100 cells per microliter with over 50
Are you talking about antibiotics?
That's like what qualifies it as like prepared now.
From
Yeah.
infectious disease perspective, it's always important to make sure that everything fits together. So one is, yes, he has peritonitis, but it's really secondary to his PD cap. And so peritoneal dialysis ultimately instilling fluid into the peritoneal cavity and using the peritoneal membrane to help allow electrolytes and metabolic waste to diffuse for all of the urology versus hemodialysis, putting into the machine, roll blood out, and hopefully filter it and put it back in. So yes, he has clotting effluent. Yes, he has Citrobacter growth, but also looking at from a diagnostic perspective, his white blood cell count was greater than 100 on the initial TB fluid analysis, and it had at least 50% nuclear
Per month.
lymphocytes.
So 91.
And so he had 3,005 white blood cells and 83% BMS. And so certainly based on these findings, plus the subjective criteria, he certainly meets criteria for, or his subjective complaints, he certainly meets criteria for PD cap associated peritonitis. So if we look at his drug-related problem, looking more so from maybe an assessment perspective, what do you think about the overall workup? If we say group number 12, what do you think?
I'm sorry, could you repeat that question for us?
So from the assessment perspective, identifying his drug-related problem, what do you think his drug-related problem is associated with peritonitis?
Except for him, right? What is that?
What did he have?
What's his drug-related problem?
Does it have to do with his cefepime?
Okay, so we elaborate a little bit more on that.
The dosing frequency is wrong.
What do you mean? Does it
Should
have
be
to
Q24.
Is that being the wrong drug? Is it being given inappropriately? Is the dose inappropriate?
Frequency.
I don't think it's being given correctly.
Okay.
Wait, no one said, go back.
How
Yeah,
would
what did you just
prefer
do?
this to be?
Supposed to be Q24. Daily dosing.
Did you say it?
No. Just playing.
I'm just mentioned.
And I think it should go in the problem side.
I think it's supposed to be given into the peritoneal space and not IV.
Okay, so should ideally be given intraperitoneal. So I agree. IV is preferred. One of the things to, in this gentleman's situation, that has to be considered in terms of being able to give an antibiotic intraperitoneally is, will the PT catheter, will the access be removed? And so there was some debate in terms of, are we going to remove this PT catheter or not? I don't know why it's now bouncing all over the place. And towards the end of his admission, towards the latter part of the notes, it does not appear that's the case. intraperitoneal centipede is typically preferred compared to IV in this situation when it's not going to have a catheter. So, in my opinion, I certainly agree with this, but I would overall call this really inappropriate treatment of PD, catheter, associated peritonitis. I agree with septum wasn't administered correctly. Is there anything else, group 12, that you found that was not necessarily appropriate in this gentleman?
All right, do y'all still want to continue to listen to him?
Yes, yes.
Okay, because I can restart the
We
system.
could probably increase the
It
dose
came back for like a second,
every
and then it went away.
Oh, I mean, you can do that.
Oh,
I
yeah,
can
you-
restart it, but it takes like 3 minutes for it to come back up.
Oh, that's.
Yeah, what?
So
I think that one said we stay with the
I'm
IV.
gonna leave it with everybody. Y'all wanna?
So,
No, you do what you.
Yeah, you can
need
restart
to
it.
do. I thought you meant you were just gonna turn them off. I mean, which I'm not opposed to either, but, you know.
So you blame me for it later on, right? All right, I'm gonna restart it, so.
Sounds good.
No, don't tell him. I just want him to be like, Augusta? Where you at? Are you gone? Did you leave? See you. Goodbye. It was so nice.
When are we gonna have that?
When are we gonna have a group nap time? Right?
I think this is now, yeah, like this is just not a sign.
How many 2 minutes is that enough?
I slept during that entire health services
I know, I was really freaking jealous. What?
I've
She
been
was
up
sleeping up there.
during our health services class.
Who was?
Me, I had like a sweater imprint on my face.
Hey, that thing was good, man. That was a good nap.
If I didn't take a nap, then there's no way I'd make it to
You're
work
the
today.
best believe.
You really are.
I hate back insurance. You need my whole life story.
Aubrey, you reminded me I need to do
Me too.
one.
What, Dave? What you need? Someone you know?
That is my nephew.
Right now?
Yeah, it's one on the Wisconsin transfer break. So, my brother-in-law, their teacher's very
It's fine.
I think he's just like, oh, there's no new problem.
Wow, what a Monday.
You know what, we're just gonna have to have this class on Friday.
How long does it take him to do a background check?
When did I
I
start?
don't know.
I'll just wait.
Oh, no. It's coming back. Look, that's it. Camera's not coming
It's okay.
So how open to this place? Yeah. It's so fun. So cold. I'm totally excited to appreciate this wind right now.
what are you saying? Okay. All right.
We got it.
Augusta, can you hear and or see?
Okay.
Yes, sir.
Okay, so everybody's running top speed now. For now. So we were talking about septine dosing and knowing this guy has some renal dysfunction. So I would say in this situation, I would not increase the septine dose to 2 grams every 8 because he has renal dysfunction as evidenced by being on peritoneal dialysis. Now, certainly being aggressive is important. Information that is also important that really and truly I think would fall under the objective criteria are the fact that he got vancomycin on admission, that he got gentamicin also on admission as well, both of which have been stopped. He's on 17 1 gram IV Q12 hours. He's also on ciprofloxacin 250 milligrams every 12 hours. And so we talk in this class about applying guidelines and making sure that you use evidence-based medicine as much as possible. Can everybody still see that font?
Yes.
Is it Q24? I may have written it down wrong. Thank you. So Cipro 250 Q24. So the purpose of this, and I put a link to these guidelines, the peritoneal dialysis guidelines, in ELC so that you would have access to this. I've never understood why this, and when you get into guidelines, tables and algorithms and flow charts, all that stuff are your friends. Most of the really high level executive summary stuff is going to be in a table, is going to be in some sort of algorithm, and then you'll go read the text in and of itself to find out the detailed information. But if everyone can see this, it talks about what goes on to start in terms of starting intraperitoneal antibiotics as soon as possible after you've gotten the culture, after you've gotten PD fluid. And then it becomes, what do we start? Do we start gram-positive coverage with a first-generation cephalosporin like cefazolin or vanc if we're worried about MRSA? Gram-negative coverage, are we looking at a third-generation cephalosporin, say something like ceftazidime or an aminoglycoside like Gent, Tobra? And then we're going to continue. We're going to make sure and see how we do overall. If we back out of this, we've already done this step. That step's already been done. You can argue and say that it wasn't done ideal because he got IV Vanc, he got IV Gent. Then we changed him over to Cefbeam, changed him over to Cipro as well. And so we can't really do anything about what's been done in the past. That's been done 4 days ago. It's here and gone, but he didn't get necessarily ideal coverage. We know that he has a gram-negative rod. Citrobacter is a lactose-fermenting gram-negative rod growing out in his peritoneal fluid. So if we scroll and we find the this is going to work. If we scroll and we find the algorithm for how to treat gram-negative bacilli from a culture, we'll see that we treat it based on susceptibilities. I don't personally like the word sensitivities because it makes me feel like organisms are going to cry, and I just don't feel like they have that many feelings, but we may differ. There's also a typo in cephalosporin versus cephalosporin, but either way. So it talks about gram-negative coverage based on some susceptibilities. We have those. We can switch into a third or fourth generation cephalosporin, so again, something like ceftazidime or cefepime, depending on what our susceptibility profile is. And then we needed to repeat his dialysis effluent cell count in a culture at day 3 or day 5. And so he had 2 separate PDCAT fluid, or 2 separate dialysate fluid analyses. And so the second one had only 67.7 white blood cells, of which 7% were PMNs and 93% were mononuclear. And his red blood cell count was 21.1. So ultimately what we can see from the initial effluent versus the subsequent is that we've decreased his white blood cell count in the effluent a little bit. His neutrophil count has also decreased, again, in the effluent. He's been on a whole host of antibiotics. So I agree with you that going forward, the 17 is inappropriate in terms of it being IV. But he's also on Cipro, and so that's another problem we need to look at. And so if we go back to the guidelines and we apply these, we look at what all went on. And so we assessed him from a clinical improvement perspective, and we looked at him at day 3 to day 5. If he had clinical improvement, we can continue antibiotics, versus if he didn't have any. And so depending on what we grew now, we didn't grow Pseudomonas, we mixed gram-negative, or gram-negative and gram-positive. We grew an other gram-negative bacilli, which Citrobacter fits. And so we'll need a total of 21 days. And so the question really comes down to, what are you going to do going forward from the plan perspective? We know that he needs 21 total days. He's already got 4 days of therapy, so we need 17 more going forward. What are we going to do from our new plan perspective? Group 23.
We were thinking of switching him to Augmentin for an outpatient therapy since it's susceptible.
How much? How often?
He's at 875 twice a day.
How did you determine that dose?
Just kidding. Be 500 milligrams every day.
So how did you determine 500 daily?
Because of his end-stage renal disease.
Okay, so he has some sort of renal dysfunction, so his dose would need to be adjusted. So most beta-lactams, including cephalosporins, penicillins, monobactams, estrianan, carbapenems, are renally dose adjusted. There are a couple that are not, things like nafcillin, oxacillin, ceftriaxone is not renally dose adjusted, but for the most of them, some sort of penicillin, cephalosporin, carbapenem will need to be dose adjusted. So you can certainly do an oral beta-lactam. That can seemingly be a reasonable option. Does anybody else have a different take? Did anybody want to do intraperitoneal antibiotics?
What?
Or would intraperitoneal antibiotics be appropriate? Should we keep the Cipro? So the biggest thing I think in terms of picking what antibiotic to send out on, obviously you're going to look at what his indication is. We know what we're treating, but you're going to look to make sure that the first question I think in this perspective is, does the drug penetrate the site of infection, or does it achieve adequate drug concentrations at oral varenicline certainly should. I think that could be a perfectly appropriate choice. However, I think from a convenience perspective, maybe giving him or continuing something like intraperitoneal cefepime would also work as well. And so stopping the Cipro.
Why does it fall so much? I didn't mean to sound rude.
To finish out 21 days. And so the other thing that is also in these guidelines that I think are really helpful is, sorry if anyone's getting busy, they have this really nice, big, huge table in terms of how much drug to give intraperitoneally if you're treating peritonitis. So you can look and see cefepime, whether it's an intermittent with one exchange or whether he's doing continuous exchanges. The nephrologist will be able to answer that question in terms of what he's doing. This patient was just doing intermittent exchanges, so he would just do a gram a day. And so what typically happens in a hospital perspective is you'll get an order for intraperitoneal antibiotics. The dialysis nurse will bring you a typically anywhere from 4 to 6 liter bag of fluid, and you'll instill the antibiotics into that dialysate fluid, and they'll take it back to the patient, and they'll be able to do peritoneal dialysis with it. So I think either option is perfectly appropriate as long as you get rid of the Cipro in really both situations. I think either of those would be perfectly appropriate. You could certainly argue and make a case to do oral Cipro and finish it out. I personally am not a huge fan of fluoroquinolones when I don't have to use them, given their side effects, given the risk of C. diff. He has a couple other drugs that can certainly interact and chelate with the fluoroquinolone. That would also be a potential issue. So I think that there's some pros and cons in terms of continuing on with an oral fluoroquinolone. Does anybody else have any different plan?
I have a question, Dr. Testing,
Okay.
about the medication to send the patient home on, which was on the quiz. I'm wondering what was the correct answer.
I would have to go back and look at all the choices because I updated them quite some time ago. I don't remember all the choices off the top of my head. But if you would like, you can send me an email, we can talk about it, and go from there.
The quiz answer was cefepime.
Oh.
Thank you.
I don't even know what quiz question she's talking about.
She's asking about the last one.
So, problem number 2.
Dr. Chastain, can I ask a question before you move on?
Sure.
In the guidelines, it mentions that you could use 2 antibiotics to decrease relapse and recurrence. Is that something that you would just kind of consider, or would you just choose the one?
So, double coverage is something that you're going to run across in all sorts of disease states, all sorts of places in terms of an ID perspective. Everybody likes to, we're America, we like bigger things, we like faster things. More is always better. In terms of all of the data and the large bulk of the studies that have been done looking at double coverage versus single coverage, once you know the susceptibility of an organism, there's really no difference in mortality. And I think mortality is the bigger marker to look at. I think if you had something, say, like this patient who had 3 or 4 different bouts of peritonitis, and he's recurred multiple times, then I would consider maybe giving him a second antibiotic. But I think in this being his first attempt, we salvaged his dialysis catheter. He got better much faster. I would be comfortable giving him just one single drug.
Thank you.
You're welcome. Group number 17. What is your second problem?
My group is
Oh my god, he just called on y'all?
Yeah.
What did he ask?
What's the second problem?
His,
Should I
not
say the
continuing
HIV?
his HIV drugs, yeah.
He's only taking 2 of his HIV medications as compared to the 4 that he was taking at home.
Okay?
If asthma doesn't know, what makes you think that?
It's called a computer.
Okay, so from a subjective, objective perspective,
Thank you.
what all information do we have to be able to say that?
It looks like inpatient he was getting the darunavir and the ritonavir, and then at home he was taking those in addition to abacavir and lamivudine.
Go, Oscar. You pronounce those like you're a pharmacist.
I cannot type.
I feel like our pharmacist who's still
Oh, my group is back. Oh, they call on us?
Yeah.
Oh.
Rupture in the gut.
Okay, so in terms of assessment plan, what do you think, what would you do going forward?
I think he just needs to be started on his entire outpatient regimen if it was what was working for him. And I think I saw a CD4 count, but it was old, so a new one would be nice too to assess if the regimen's
Okay, so you get a new CD4 count. So would you just restart him straight out of the gate and put him back on the back of your movie?
I don't know.
I mean, that's just rude.
I don't know.
What did you just say about that?
Really? I don't know.
And so the reason I ask that is because home med recs can be flawed, certainly. I've seen patients who have had 7 or 8 HIV meds on their home med rec because it wasn't updated, or maybe they only had one single drug. And so I think the first thing to do, while I don't disagree with restarting it, I think the first thing to do would be to do some sort of investigative work.
Okay.
To either talk with the patient and verify this regimen, or maybe call his pharmacy or his physician's office to get some sort of records to make sure that's the case. We don't know in terms of, was this an old regimen that he may have failed and now he's on something totally different? And if we give him this older regimen, perhaps he goes on to develop further resistance, or maybe he doesn't even take it. Maybe, sure, that's what he's supposed to be on, but I hadn't taken it in 6 months. That just may not be his thing. We've had patients who don't want to take HIV meds. They feel like they've had it for 10 years, they've done fine, they don't even want to consider it. We had a young lady earlier, I was going to say earlier this week, but earlier today, who claimed she had been taking a drug called Complera for the past 3 years. Every single month, never missed a dose, filled her every time. However, when we called the clinic that she was supposed to go to, they hadn't seen her in 4 years. And so where was she getting Complera? That was the clinic she said she was going to. So you're always wanting to make sure from a compliance standpoint, these patients are taking it, this is truly what they're supposed to be on. Because you can cause some significant collateral damage if we end up starting and it's not an appropriate regimen. But I agree, if everything checks out, I think you could restart it. For the time being, however, until we figure out all this information, I would stop this darunavir and ritonavir. So one of the things that I'll always talk about is the golden rule in HIV is all or nothing. So he either gets all of his medicines or none of his medicines. Until we know what the whole process is, I'll stop them all, we'll figure it out. It'll be okay to hold them for a couple days, even out to a week potentially, and we can put them back once we know whether this is the case or not.
Okay.
But a new CD4 count certainly would be helpful. How else do we monitor HIV treatment?
I don't remember.
So CD4 count is part of it. Good. We also do an HIV RNA viral load. to make sure whether he has a detectable viral load, whether he doesn't. And again, that goes back to compliance. Has he been seen? The other thing that I'm a fairly big advocate for is not ordering tests that don't need to be done. Maybe he was seen in clinic last week and had a new CD4 count then, and we can go ahead and get that information rather than having to charge him from an inpatient perspective. Most CD4 counts and viral loads tend to take about 3 to 5 days to come back. So it's not going to be an immediate result like a white blood cell count or, say, a potassium or sodium. So by knowing this new CD4 count because you won't know it in 3 to 5 days, does that help us any in this moment, in this period of time? Anything else on is inappropriate HIV methods?
No, I think you've tortured me enough. Should I say no?
Yeah.
Is he asking me?
I don't know.
Is this our group?
Yeah.
Okay.
Okay.
So problem number 3.
I don't know, does PJP prophylactic go with that problem? Well, it's too late now.
Group number 11.
Another group.
Precisely, Aaron.
And also, I thought, isn't the cutoff for PJP 150?
I think.
And that's why I was like kind of
No, I
on
thought
the
it was
quiz, but then I
200.
saw the next question, so then I was like, okay.
Yeah,
that's
that's one reason I chose it.
I thought the talk show class one was like 150.
I couldn't remember. Maybe it's 250 for PJP. I don't know. All those numbers
I know
are
like
not
the
in my
under
brain
50 was the
anymore.
cryptococcus, and then
Yeah, 'cause
100
that's
was
like
max.
the worst one.
Yeah.
I don't know. What?
Okay.
Okay.
Group number 11.
Sorry, we're discussing.
Very good. Making sure that we haven't
Did you
had
finally get a Lily one?
technology.
That beautiful cut crease.
It's like when she does her chips, she almost like it once, she puts one in the board.
She makes herself like a robot or something.
Oh, it appears so. Look at this detailing.
She's a cyclops.
So we've been comparing notes, and I think the one thing we had in common was DVT prophylaxis.
Okay. So from the subjective objective portion, what information do you have to support that problem?
He's on enoxaparin 40 milligrams, and he also has renal dysfunction, so it's not recommended.
Cold.
Okay, so from an assessment plan perspective, from a monitoring perspective, what should we do going forward?
That's a lot going on.
Which is good. Yeah. Who's gonna write? Yeah, that would end up doing it all. But
Another half skull. A snake.
So we were thinking about just based on recommendations, maybe moving down to 30 milligrams per dose.
Did we do heparin?
Sorry, we're trying to figure out because it's actually not recommended in, if there's an alternative, because it's not really recommended in dialysis anyway.
Okay. So are we gonna say scrap the 30 milligrams or keep going?
You feel me? You feel me?
On that one, it kind of depends on his actual creatinine clearance, which we're trying to look back up.
Oh, yeah. She's good when she's good. It gets done. She's very, she's too much. But I guess that's the third. We went. Yeah. She did herself. She was getting to
Can we just discontinue it?
Okay. So discontinue Oxycodone altogether.
Put on heparin.
Yeah.
Okay. And so does he need any DPT prophylaxis?
Heparin.
If he's being discharged, does he still need it?
So certainly, if he's on his way out the door, maybe he doesn't need it. Let's say he's going to stay for another 4 days. What would you do?
Heparin. You couldn't find what you want. Heparin. Oh God.
I think that we should start the patient on heparin.
Okay. So how much? How often?
Oh my God. 5,000 units. So cute. It's the only dose I can think of.
Yeah,
off the
that's the
top of
only
my
one I
head.
know. I don't know what the weight.
I don't know how to do a drip.
What is he asking?
3 times a day.
Heparin. How to give it.
Is it 5,000 units every 12 hours?
12.
Subacute, some.
Subacute. Okay.
I was 8, 3.
I thought so too.
And so where did you find the information for this? For him needing DPT prophylaxis, the dose of heparin. There were a couple questions in terms of did he already receive heparin? And then how do we monitor this going forward?
What do you monitor for heparin? PT or APTT? Do you look at PT or APTT for heparin? APTT?
Pretty sure. Like 6 hours after you get the
Yeah.
first dose.
Like before? Like, what is it, like right before and then 6 hours
Something
after?
like that, yeah.
CBC. Platelets.
Yeah. We don't need no hit. Is that what he's asking? Monitoring?
I think he said monitoring, yeah. What was special about these?
They were just Snickers.
I thought she said it was like something different. No.
No, she's like, I have extra cake. I thought you wanted to use it.
I thought they
So,
were saying something different.
for
No,
renal
it's not the
failure,
Snickers,
there's
it was something else.
adjustments
It
for
was like
heparin,
midnight.
and then you could monitor the APTT, I think like 6 hours after you give it.
Okay, so do we monitor PTTs in sub-Q heparin?
Guess not.
Or is it only an IV heparin?
IV.
Okay, so maybe PGT is not the best thing to monitor. So what else?
Signs of bleeding.
TB3.
What does heparin do? It's hoping to prevent the blood clot, right? Deep venous thrombosis. So if we were to potentially prevent his ability to form a clot, then what's he at risk for potentially?
Bleeding.
So bleeding, so we can monitor for signs and symptoms of bleeding. What, any lab values that could help? maybe you could potentially look at his platelets, his hemoglobin, and maybe even hematocrit. And so earlier, someone mentioned that his hemoglobin and hematocrit were already a little on the lower side. Does anybody know why his hemoglobin and hematocrit would be a little bit low?
Anemia of chronic disease.
The pharmaceutical robots in the back have spoken.
The patient is an end-stage renal, only has anemia of chronic condition.
Good. So anemia of chronic disease. And so his baseline may be around 10, but what you're looking for is you're looking for maybe a significant decrease, maybe 2 grams or more, or maybe a major drop in his platelets.
We gave her money for a hot sheet after. Yeah.
Well, together, and so at the time of yeah, so
Any questions on that?
she came rolling in the wheelchair, rolling in the wheelchair, and I'm like, she didn't count it, but I guess it's not.
Group number 8. What is your problem number 4? Or what would be the next problem, rather?
We want to add PJP prophylaxis.
Okay.
Yeah, that's what I was gonna say.
So from a
Even if
subjective, objective
Even if it's not.
criteria,
She speaks like
what information do you have to support that?
His CD4 count was below 200.
Oh, okay.
Hey!
Both of y'all to Kendall.
What?
We talk shit about Darren and Kristen all the time, is what I said. We're talking trash, Kendall. Laying that down.
How you doing today, Aaron?
I mean, I probably have like $1,000 repair on my car, but other than that, it's fine. I got savings for a reason, I suppose.
Do you need to take you home?
Suhan's gonna take me into the car place.
Alright, we're back, we're good.
Hopefully it makes it.
That's very sweet of her.
We see and hear you in Athens.
Thank you. How about Augusta, Savannah?
We can hear and see you in Augusta.
Thank you.
We can see and hear you, ma'am.
Perfect, thank you. All right, so we had group number 8, you were talking about nemesis prophylaxis. So from a subjective objective perspective, what information do you have to support that problem?
He had a low CD4 count.
Okay, so how was low?
155, so it's below 200.
155. So from an assessment plan and monitoring perspective, you would say that it's below 200 and therefore he's indicated for what?
For PJP prophylaxis. Of Bactrim 1DS tab daily.
Okay. And so is Bactrim renally eliminated?
I didn't even think about oxygen.
Yes, sir.
Is that an appropriate dose for someone who has poor renal function? No, maybe not. We're checking. Maybe not.
We did Dapsone 100 milligrams QD.
Okay, why did you pick Dapsone over Bactrim?
Because of their poor renal function, so and Dapsone I don't think had any renal risk adjustments.
Okay. Is there, do we have an update on Bactrim?
Based on his creatinine clearance, we shouldn't give him Bactrim.
Should give Bactrim.
No, sir.
Okay. What if he were on hemodialysis? Would you give him Bactrim?
Yes, we could.
Okay. So I understand what you're saying about creatinine clearance. It says to avoid it. Why do we want to avoid Bactrim in someone with poor renal function? So can Bactrim cause an acute kidney injury?
Yes.
Yes. Any electrolyte abnormalities that Bactrim could cause?
Hyperkalemia.
It could certainly cause hyperkalemia. Can you name the other drugs that can cause hyperkalemia? So I was told potassium. I won't tell you about it. Any other drugs that are not potassium? They could increase potassium.
Spironolactone.
Okay.
ACE inhibitors.
That's not how you spell it.
I can never spell
We're
it
gonna leave
either.
it at that
It's
because I don't
okay.
know how to spell the rest of it. ACE inhibitors, good. Anything else?
Carbs.
Good.
Potassium.
Any other drugs, drug class?
Already on there.
I mean, I'm sure
No.
there are.
Okay.
I think thiazide.
So how about calcium-sparing diuretics?
That's
This is
what
spironolactone.
spironolactone is, but okay.
Listen, he's
So there's
HIV stuff, not.
more, but that's spironolactone.
Eplerenone.
But, so those could certainly be taken into account, not necessarily in this patient, but especially in the South where tons and tons of patients have hypertension, have some sort of renal dysfunction, or are on an ACE inhibitor for that matter, for blood pressure. Certainly something to consider when putting patients on Bactrim. So, in someone who we'll say is maybe CKD stage 3 to 4, then Bactrim should probably be avoided due to the risk of worsening their renal function. However, in someone on PD or HD, as long as it is dose adjusted appropriately, then it should be okay. We've talked a little bit about creatinine clearance in someone who's on PD or HD. So a couple things you have to take into consideration in assessing creatinine clearance in patients on HD or PD. So you can certainly calculate it. You can calculate it all day long because you're using an indirect marker, you're using serum creatinine, you're not using what's actually being output in urine. But the first question becomes is you have to ask, are they making urine? If they're not making urine, they're not able to kick out creatinine. And all the creatinine is getting filtered from some sort of dialysis membrane, whether that be HD or PD. If they're making urine, then depending on how much they're making, for the most part, you can assume a creatinine clearance of about 10 to, we'll say, 20 to 30 at max in terms of their residual renal function. But again, if someone's on dialysis that doesn't make any urine, they're not going to be able to, they really have no creatinine clearance, so to speak. Their creatinine clearance is all based on a dialysis membrane. So I think if you could do a couple different things. I'll go down here. You could do Bactrim anywhere from, we'll say maybe 1 DS every 48 hours. And be okay with his renal function. Some patients prefer something every day, a scheduled regimen. I know certainly I would, versus some don't really care if it's a couple times a week or every other day. I personally get confused and probably end up taking it every day or not at all. So talking with the patient, making sure that they're on board with what your plan is certainly important as well. Any questions? Group number, let's do 15. What is your next project?
Hey, Masha, is it from 4 to 9 on Wednesday? Is my shift from 4 to 9 on Wednesday?
Yeah.
Same shift, different day.
He's on a calcium reducer and also a calcium supplement.
Okay. All right, so from the subjective, objective perspective, can you tell me about what information you have to support that?
It's on his home med list, but he has a normal calcium levels.
Okay, so what's on the home med list?
Cinnamon calcet and calcium acetate.
Okay. And so those are on his home med list. Is he getting them inpatient?
Yes.
Okay. And so from an assessment plan and a monitoring perspective, what do you do to fix the situation?
Maybe take them off both and monitor their calcium levels.
Okay, so what is cinacalcet for?
Isn't that for the hyperpara, whatever? Oh.
I think it's something to do to get that, since it does something for the blood, something. Let's see.
It's for parahypothyroidism.
Okay. So for hyperparathyroidism, correct? And so what does it do?
I guess, were you able to plug the paracalcium whatever into the thing? Because it like wouldn't even pull up on Lexicon when I tried to put it in a drug interaction checker. And I was like, is this drug made of? No, not that one. There's another drug.
Yeah, she's on a different one.
And I was like confused. I'm like, did he just make up a drug that like doesn't exist?
It can be used to control the level of phosphate in the blood for patients on dialysis.
Okay.
Something, I know it's something.
Yeah, because calcium and phosphate.
Are you gonna dictate right now?
No. Was that on the last test?
That was for calcium acetate, is what I meant that for. Sorry.
Okay. So how about cinacalcet?
It's a vitamin D analog.
What? The cinacalcet or the paracalcet?
It's the K6 Indigo guidelines do not recommend that you use vitamin D analog because it's not on dialysis. Chronic kidney disease, it just degrades that. So it's only indicated for people on dialysis.
Wait, didn't that say for not in G3 to G5 what?
It is like they had reserved it. Like,
oh, reserved for.
If they're not on dialysis, then don't.
So it can be used to treat secondary hyperparathyroidism in patients with CKD who are being treated with dialysis.
Okay, so what does that end result look like?
Of what? I'm so confused.
Oh, both of these shows.
What does hyperparathyroidism lead to in someone who's on dialysis?
Does it increase or decrease calcium level?
To normalize them, so you want to. It decreased it.
Hypercalcemia?
Okay, so can be used for hypercalcemia?
Yes.
What else? Would it also potentially help? So helps to, or help?
He's just not.
Okay. So can also lower phosphorus in blood. So in terms of,
Oh, hypophosphatemia.
would you stop both of these?
No.
Maybe just the calcium instead of the other one.
Okay, so maybe just the calcium acetate instead of the other one. What is his phosphorus currently?
We don't see one.
Right. So no phosphorus. Would you automatically start changing his medicines now, since he's seemingly stable, he's gotten better since his inpatient stay, and maybe getting ready for discharge, or would you say, let's order a phosphorus and see what it is to assess how well his medicines are working?
We should order a level.
Okay, so I think that it would be best to order a phosphorus on this next set of labs, or maybe you can add it to this morning's labs to assess the efficacy of the drugs prior to stopping. And again, that's based on how he clinically looks. So he looks okay overall. He's potentially going to be discharged. The other thing to do is you can also talk to the nephrologist and see why they put him on both, and see if there's a distinct reason. But certainly something to consider in terms of going forward from an inpatient versus an outpatient management. Group number 1. What is your problem for your next problem?
He's not on aspirin.
Okay, so no aspirin.
Yes, he is.
In the hospital, but not.
Okay, from a subjective, objective perspective,
Which one?
what information do you have to support that?
Oh my god.
He has a history of a TIA last October.
Okay. Any other information that would be helpful to know?
Aspirin 81 milligrams daily was initiated in the hospital.
Okay, good. Okay, so from an assessment plan and monitoring perspective, what do we need to do?
The AHA guidelines for stroke recommend aspirin 81 milligrams daily for secondary prevention indefinitely.
Okay, did you say a dose of aspirin? I believe you did.
81 milligrams daily.
Okay. Okay, so you want to keep him on what he's currently on and discharge him on that?
Yes, sir.
Okay, good. How would you monitor, or is there anything to monitor for starting him on aspirin?
Signs and symptoms of bleeding, and then we could also counsel him on the acronym FAST in case he has another stroke in the future.
Okay. Who else would be, so if you're going to counsel him on this acronym, he and any of his family members or close relatives that see him or live with him would certainly also be somebody to consider in terms of counseling. But very good. Anybody else have anything to add or questions about this one? Let's see. Let's go with group number 3. What is your next problem?
Hypertension.
Okay. And subjective, objective information to support that?
So his vitals have kind of fluctuated from 188 over 103 to his lowest being 127 over 73. And on admission, his blood pressure was 156 over 83. His home meds are labetalol 200 milligrams once a day and nifedipine 60 milligrams twice a day. And inpatient, he's currently on nifedipine 30 milligrams twice a day. So I guess kind of want to confirm what dose he's been taking, or if that's kind of the one that they want to stick with. And then inpatient also the labetalol 200 milligrams once a day.
Okay. What is his, from an assessment plan monitoring perspective, what do you think?
The labetalol should be administered twice daily rather than once daily.
Okay, so would you just do 200 twice a day?
That's what I have written down.
Okay, so you're saying that's what he is currently on?
He's on 200 once a day, but it should be 200 twice a day.
Okay, so you would just double it straight out of the gate?
Yes.
Okay. What are you trying to achieve?
Control over his blood pressure, and looking at his pulse rate, it's in the 90s, so he should be fine with the lowering of his heart rate with the increased dose.
Okay. What goal blood pressure are you trying to achieve? Depending on how aggressive we get, I mean, we can get him into the hundreds.
Say 140 over 90 due to his comorbidities and his trouble getting to that goal blood pressure.
Okay. Does everybody agree with 140 over 90?
I don't know.
Probably less than what it currently is. Just a guess.
So we would leave him on, what would you do with nifedipine from a 60 versus a 30 perspective?
What you doing? Oh, I'm doing a class listening to your chest CJ, it sucks. It sucks really
We want to confirm the home dose, and if it's correct, we want to keep him on that. That's 60 milligrams BID, because that's the maximum dose of nifedipine.
Is there any interaction with nifedipine and some of his other medicines?
I have one. I haven't eaten yet.
The Darunavir and ritonavir, since they're 3A4 inhibitors.
Does that increase and decrease them?
I started following puppy pages on Snapchat.
It's worth it. It's pretty
Oh,
cool.
I follow one called.
Oh, well, maybe. I don't know.
It'll go higher, have a higher effect of the nifedipine.
Okay.
Oh, it's just called Pets.
So if we were to go to 60 twice a day, then theoretically he's going to get more than 60 twice a day. And so perhaps that's why he decreased it to 30 twice a day when he came inpatient, given the potential interaction. Although we don't have documentation of that, so we can only assume at this point, since seeing him 4 days in. So what are we going to do now?
Oh, he's wearing a tie.
We agree that the nifedipine should be decreased to 30 milligrams twice a day if he ends up going back on his HIV regimen.
Okay, so we would do labetalol 200 twice a day, and nifedipine 30 twice a day, and that would be it.